Hi, welcome to Microbiology Mentor. In this session, we will be discussing about NEET PG Recall Microbiology question with detailed explanation. And since these questions are asked from the important topics, we will be discussing those topics in details. So let's see the question. A farmer presented with sinuses with discharging granules on his swollen leg. The granules were cultured and examined. Which of the following statement is correct regarding the scenario? Option 1 involves the skin only, no deeper tissue involved. Option 2 lymphocyte accumulation is present. Option 3 caused by bacteria or fungi. Option 4 is spread by hematogenous route. So since this is a recall based question, so there is a chance that there is some maybe a odd grammatical error or some clue words missing, but more or less the topic is there, which is an important topic and which should be discussed. So let's see what is clue to the diagnosis, because we have to diagnose this clinical condition before we reach to the conclusion in form of the options which may be correct. So let's see what are the clues. So the clues here are farmer, sinuses with discharging granules, and swollen legs. So these are granules, these are some of the clues which help us to reach to a diagnosis. So what is the clinical diagnosis here? The clinical diagnosis actually fits in a triad of clinical presentation which is pathognomonic, and it is subcutaneous mass, multiple sinus formation, and purulent seropurulent discharge containing granules. So this is what is the clinical diagnosis. Clinical diagnosis is mycetoma. It is mycetoma. Okay, so it is mycetoma because it is having swollen leg with multiple sinus present and discharge containing granules. Although painless word is not mentioned in the question, which I hope may or may not be missed because this is a recall question, but yet we assume that this is, even if it is not present, it fits to the triad of this clinical condition, and it is a true case of mycetoma. But remember, just mere diagnosis, reaching to the diagnosis or diagnosing this case as a mycetoma will not suffice, because what this question wants is some deeper knowledge or some insight knowledge of the about the text. So that's why I have chosen this topic, and I want to explain you each and every nuances, every aspect of the topic, so that it may be clear, and in case any future question or future questions are asked, which is very likely, so you may be able to solve those. So where do you find mycetoma? Most of the textbook have described under subcutaneous mycosis. So mycetoma is under subcutaneous mycosis. Subcutaneous means it primarily involves dermis and subcutaneous tissue. So it is primarily involving, the pathology is of dermis and subcutaneous tissue, and other clinical condition with subcutaneous mycosis are sporotrichosis, another important topic, and chromoblastomycosis. So we will be discussing this separately some other day, but today we are discussing about the mycetoma, which comes under subcutaneous mycosis. So one thing is clear, that it primarily involves dermis and subcutaneous tissue, and at the same time it is a neglected tropical disease. It is one of the neglected tropical disease. So let's go further. So this was in ancient time called Madura fort, because this is quite old. The history of this clinical condition is quite old, because it was first described in Chennai, which was then called Madras. So let's see the etiological agent. This mycetoma can be caused either by fungus or bacteria, which are members of actinomyces. What is actinomyces? These are filamentous bacteria. These are filamentous bacteria. These are filamentous bacteria. So these are filamentous bacteria. So these resemble like fungus, but they are not fungus, they are bacteria. So it is very clear here from here that mycetoma are caused by both fungus and actinomyces. So those book which mentioned mycetoma under subcutaneous mycosis, it is partially correct, because a part, that is the etiological agent of EU mycetoma, may be correctly clubbed under fungi, but the actinomyces causing mycetoma are actually bacterial. So that should be taken in care. So let's see, the when the causative agent is fungi, it is called EU mycetoma. EU mycetoma. So remember, it is EU mycetoma. It is fungi, so it is EU mycetoma. So a mnemonic will be, you just put one more horizontal line here and it will be EU mycetoma. And if the causative agent is bacteria, it is called as actinomycetoma. Actinomycetoma. So one thing is again clear here, that the causative agent can either be a bacteria or a fungus, both filamentous in appearance. So this is clear from here. So one thing here only I would like to discuss, that what are actinomyces. Actinomyces actually is a big family of bacteria which are branched filamentous like in morphology, and it includes many members, both aerobic ones and but both anaerobic as well as aerobic ones. And among those, the important one which are the causative agents of mycetoma like conditions are actinomyces, nocardia, actinomadura and streptomyces. So let's see in detail the causative agent of condition of EU mycetoma, where the fungi is a causative agent, agent. E, you see it is as F, EU mycetoma caused by fungus. So the important fungi are Madurella mycetomatis, Pseudo Escherichia boydii, Madurella griseae and Scedosporium apiospermum. So these are the 4 common fungal species causing EU mycetoma. Okay, among actinomycetomas, the important ones are Nocardia brasiliensis, Streptomyces and Actinomadura species. Okay, so let's move ahead. What are the clinical feature of this condition? So the disease start with a history of trauma which may not be given by the patient, because the incubation period is as high as 9 months. So it varies from 3 months to at least 9 years even. Okay, so with this long history, the patient most of the time forgets about the history of trauma, but the disease begins as a firm, small, painless subcutaneous plaque or nodule on the lower extremity, usually foot, because this is the area which is most of the time exposed, and the agriculture worker or farmer is actually most of the time barefooted, and there is a history of trauma, and after that this condition occurs. So at the beginning, it is painless subcutaneous plaque or nodule, which during the course of illness progress to swollen condition with induration, which is hardening with multiple discharging sinuses. So there is presence of multiple discharging sinuses. You can see here there are multiple discharging sinuses. The sinuses are at different stages of healing. So some of them can be healed, some of them are still healing, or some of them are healed and there may be a induration present. So, and what is another clue to the diagnosis is there is the discharge. If present, which is most of the time present, actually contains grains. So they are gritty like discharge present. The patient will complain that there is some discharge with gritty sensation. So these discharge or grains actually contains large aggregate of the pathogen. What it is containing the true pathogen, either fungi or bacteria itself. So let's see about the spread. So the disease, this condition is spread locally, so it involves dermis, subcutaneous tissue, but it rarely disseminates. So it rarely disseminates, and if it spreads, it spreads through lymphatics. It spreads through lymphatics, and it does not, or it rarely spread through hematogenous. So hematogenous spread, although discussed by some of the researcher, but they are rare. Hematogenous spread is rare. You may make a note that the spread is either by local means or it is through lymphatics. It is through lymphatics, which closely resemble the other subcutaneous mycosis, that is sporotrichosis. This is also important, and we will be discussing this some other day. So chronic cases, in some of the chronic cases, the sinus tract may become hard and swollen, and ultimately may sometime erode the overlying bone and give and complicate to a condition when it becomes osteomyelitis. So the complication of this condition, that is mycetoma, can be osteomyelitis, although not asked in this question, but it may be an important clue. It may be an important point to be, and it should be noted. Okay, so let's see how we diagnose it, because the other two options are according to as per the diagnosis when it say the presence of lymphocytes. Okay, so for diagnosis, what we do, there are different modalities available, in which there is direct microscopy is one. Okay, direct microscopy is one, and it is actually quite easy to directly visualize the grains, because the diagnosis is made by the visualization of grain. And how it is made? The grains are collected between two slides and it is crushed. Okay, it is crushed between the two slides. That it is crushed between the two slides, and then it is visualized by performing some stain. So what stain we perform? We do a gram stain. So gram stain, it helps to pinpoint or to detect the bacterial causes, because in gram stain the bacterial causes like nocardia or actinomyces will be stained gram positive, and it will be present as a branched filamentous appearance. Okay, it will be branched filamentous appearance. Whereas if you are suspecting the causative agent as a fungi, then you require certain special staining to stain the fungal, which can be either PAS, that is periodic acid Skiff test reagent, or GMS. GMS stands for Gomorrheas methamine silver. Gomorrheas methamine silver, both are used to stain the fungal wall. So apart from this, what you can do, you can visualize the granules using 10% KOH mount, where if the presence of fungi is there, it will be appearing as fungal hyphae. Fungal hyphae will be visible. What it does, that what this does 20% KOH will clear the cellular debris, and it will make the fungal hyphae more visible. At the same time, you are able to see a distinct color of the granules. So this color, on the basis of this color of the granules, previously in the old time it was classified as the causative agent. So you can see here that different etiological agent have different color. Even you can see here, but to summarize, the fungal granules take darker comparatively. You can make a note that here the fungal granules make a darker, like black or brown in color, whereas the bacterial granules are comparatively white or yellow in color. Exception is to this one, that is Actinomadura pelletri, which is red in color. Apart from those, they are either white or yellow, whereas Eumycota, that is the fungal causative organisms, are either black, brown, or sometimes white to yellow color. So again, apart from these two modalities, histopathology can be done, but when it is done, when the draining material cannot be obtained, and at that time what it is required, a punch biopsy is required, and you do a HNE, that is hematoxylin eosin stain of those prepared slide of the biopsy. And what you visualize there, when you observe, you see a suppurative granuloma which is surrounding the grain. And what it is composed of, the granuloma is composed of neutrophil. It is composed of neutrophil. It is not composed of lymphocyte. It is not composed of lymphocyte as it was asked in the question. So it is neutrophilic suppurative granuloma. It is neutrophilic suppurative granuloma. And you will be able to visualize grains which are actually the aggregates of the fungi or bacteria or the causative organism itself, arranged radially in the form of hyphae. So this you can see in a histopathological examination. Apart from that, yes, this is the slide which is showing your histopathological examination. Here you can see a HNE stain of this, of the punch biopsy. Here you can see this as a brown to light brown to dark brown colored this section of the grain or granules surrounded by the granuloma, which is basically made up of lymphocyte. Okay, this is what you can visualize in a histopathological examination. Further, the other modality can be culture. So culture can also be done, but most of the time it is done to speciate what is the species which is responsible, or what are the fungal or what may be the bacterial etiological agent. If you want to speciate it, if you want to know what species are responsible, then only you do a culture, and for that you choose specific culture media according to the etiological agent. Like if you are suspecting a bacterial cause, then you use the bacterial culture media, like but these are not routine culture media. These are Lowenstein Junction media, then thioglycolate broth, Columbia agar, or brain heart infusion agar for bacterial etiological agent. For fungal, you use Seborrheic agar and another Chemex agar. So you may make a note that this is also used for eumycetomas, and these are used for actinomycetomas for cultivation. Okay, now coming to the treatment part, although this was not asked in this question, but yes, it may be a question in near future, which is very likely, because here the treatment is different for different etiological agent. So if you are confirmed that the case is eumycetoma, then you need to do a surgery and followed by a prolonged ketoconazole therapy. So most of the time they respond to a surgery and prolonged ketoconazole therapy, and if it is a bacterial cause, then it is treated medically by drugs like dapsone, streptomycin, or a 2 to 3 month course of rifampicin. So the treatment modalities are different. So you clearly need to know the etiological agent so as to plan your treatment. Now coming to the question, and let's see what is the correct answer. So the farmer was having sinuses which were discharging granules, and the leg was swollen, and you have to choose the correct answer. So let's see the first option. It involved the skin only and no deeper tissue. So no, this is not. It involved the dermis. So this answer is not correct. So it is incorrect. then lymphocyte accumulation is present. So probably it is asking about the histopathological examination. So we have seen that in histopathological examination, the grains is surrounded by granuloma, which is composed of neutrophil, and it is not lymphocyte. So this answer is also wrong. This answer is also wrong. Now, spread by hematogenous route. So we have seen that it rarely spread by hematogenous route. It is either by direct spread or direct involvement, or it is, even if it is spreading, it is spreading to the lymphatics. So this option is also wrong. So the correct answer here is caused by fungi or bacteria. So this is the correct answer. Thank you. In the next session, we will be discussing some other topic.